Hello, everyone. I'm Professor Florence Thibaut from the University of Paris-Cité in France, from the University Hospital Cochin, and from the Institute of Psychiatry and Neuroscience in Paris, France. First, I would like to thank Russell D'Souza for his kind invitation to participate in this interesting meeting of the International Institute of Organizational Psychological Medicine. Then I would like to thank you, Pierre, the previous speaker. That was an interesting map of the territory, and I will move from naming what you've done, what's happening, to doing something or trying to do something about it. So I will talk about promoting workplace well-being. Why this matters for psychiatrists? 15% of workers worldwide live with a mental health disorder, and workplace conditions directly shape the clinical presentation we see every day. In addition, occupational stress is a recognized contributor to anxiety and depressive disorders, as well as burnout. So healthy organizations, work organizations, combine individual clinical care with organizational interventions. And the psychiatrist's role is a little bit difficult at the intersection of clinical care and primary prevention. This is my roadmap with learning objectives. First, to understand the models that are regularly used, GDCS, GDR, and PERMA as frameworks for workplace well-being, and we'll come back to that later. I will also identify validated interventions, so evidence-based strategies at individual as well as organizational levels. And I will try to show you how to apply this in clinical practice. We have some assessment tools, prevention planning, and treatment approaches for everyday practice. How to define workplace well-being? It's a multidimensional state. It's just not the absence of illness. It's more complicated than that. It's a state of complete physical, mental, and social well-being, according to the WHO 2022. Physical well-being means good energy, good sleep, good somatic health, and good recovery capacity in case of any incident. Psychological well-being means emotional regulation, cognition, good cognition, and sense of mastery. What does social well-being means? It's a sense of belonging, psychological safety, and quality of relationships at work. The WHO defines good mental health as a state enabling people to cope with life stresses, which we cannot avoid, realize their abilities, and work productively. About the psychiatrist's focus, this three-dimensional balance underpins resilience and burnout prevention. What are the models that I mentioned initially? GDCS means Job Demand Control Support. High demand plus low control plus low support at work leads sooner or later to strain and burnout. Clinically, map job characteristic may be used to modify organizational risk. GDR, job demands resources. Demands at work cause strain when resources, that means autonomy, feedback, support at work, meaning of the work, are insufficient. Clinically, it's broader than the previous model, and it's suited to flexible and low knowledge-based work. And finally, the PERMA, positive psychology, which means P stands for positive emotion, E for engagement, R for relationships, M for meaning, and A for accomplishment. This is clinically used to enhance well-being and recovery beyond symptom checklist. What about epidemiology and costs of not well-being? 12 billion working days are lost every year because people are not well at work. $1 trillion lost of productivity is due to depression and anxiety. 1 in 5 workers report burnout symptoms, according to recent studies from Gallup in 2023. Anxiety, depressive disorders, and burnout dominate this burden, but also presenteeism, which means you are physically present but functioning at 10 to 15% reduced capacity. And also higher turnover in toxic cultures or work environment add to the cost. 11% of depression worldwide is attributable to occupational and work risk factors. So you have to combine individual and organizational approaches, which is the solution that works best. There are some risk and protective factors for well-being. What are the risk factors? High workload, time pressure, low autonomy, low control on your work, toxic or poor leadership, workplace bullying or harassment, effort-reward imbalance, which is so common at work. What about the protective factors? Psychological safety first, meaningful work, recognition, feedback, social support from colleagues and also managers, and flexible work arrangements. There are some vulnerable populations such as women. Women's mental health at work, there are specific occupational risks. There are some difficult times for women, such as menopause and perimenopause, associated to a higher level of anxiety and depressive disorders, pregnancy and return from parental leave, because often they think that they have lost their position when they return from parental leave, caregiving for children, but also for elderly parents, and mental load, workplace discrimination, which is so often observed in women, and finally sexual harassment, which is more and more often observed all around the world. There are some psychiatric consequences of these specific occupational risks, such as an increased level of depression and anxiety disorders, and we know that women are in general more prone to depression and anxiety disorder from puberty to menopause, sleep disorders, burnout, substance misuse, especially alcohol at perimenopause, under recognition during clinical assessment, which means under treatment of women's mental health difficulties. So the key message is that sex and gender-sensitive approaches remain an under-taught component of workplace psychiatry. Evidence-based interventions. The interventions might be flexible work arrangements, how to measure the effect, higher job satisfaction. Leadership training is associated to lower burnout symptoms with better managers. Job redesign, more autonomy at work means higher productivity. Psychological safety climate means better team performance and learning. This is mentioned in several reviews or meta-analyses, as you can see on the right side of this slide. Individual level adjuncts such as CBT, mindfulness, physical exercise, they have also effects, but these effects are smaller and less durable than system-level change, such as flexible work arrangements, better leadership, job redesign, and psychological safety at work. There are some clinical tools that can be used, such as the WHO-5 for measuring general well-being with 5 items. It's a tool for rapid screening. PHQ-9 or GAD-7 or HAD might be used to measure anxiety or depression severity in case of any suspicion of anxiety or depression. MBI or OLBI, which is measuring according to Malash or Oldenburg burnout inventory to measure burnout. UWES to measure work engagement, and GCQ or COPSOQ to measure psychosocial job characteristic, not just the psychological symptoms. A few words about neurobiology of chronic occupational stress. There is a heightened amygdala reactivity associated to impairs of prefrontal regulation and executive control. Stress disrupts cortical rhythms, producing allostatic load over time. And finally, stress increases inflammatory markers with elevated interleukin-6, TNF-alpha, and CRP regularly observed in chronic work stress and burnout. So that means that burnout or chronic stress is a measurable physiological change, not just a subjective complaint. How to implement this practice of well-being at work? There are some barriers, and in bold, and some practical solutions. Barriers: lack of resources. You should start small. Pilot one high-impact intervention, such as, for example, leadership training or job redesign. Second barrier: cultural resistance and stigma. Train managers, involve leadership visibility, normalize mental health conversations. Measuring the level of well-being. Track absenteeism, track turnover, engagement. Use validated well-being scales. Numbers are used to bring back to leadership the level of well-being or not well-being at work. If another barrier is fragmented responsibility, position the organizational psychiatrist as a bridge between clinical care and system change if they need one bridge. A clinical case, a differential diagnosis at work. Andrew, 52, senior surgeon, complained of chronic insomnia, irritability, 2 near-miss errors at work. Nightly alcohol to sleep after repeated 24 hours on calls, high demand role, no protected recovery time. The audit C to measure alcohol use score is 8 at the beginning. The PSKQI measures insomnia severity, it's 18 at the beginning. So, insomnia versus alcohol use versus occupational burnouts first. So you may use CBT interventions plus brief alcohol intervention as a first step, plus change a little bit work with consented on-call redesign, produce faster, safer recovery than medication alone or CBT plus brief alcohol intervention. Audit C decreased to 2, and insomnia severity decreased to 7 after 3 months of follow-up. So do not forget to treat the patient, but also to redesign his or her work. That's more efficient. Primary versus secondary prevention strategies. Primary prevention, of course, work redesign is the most important thing. Optimizing job control and autonomy, redistributing workload fairly, cultivating high-quality social interactions, leadership development and improvement, clear role definition, and psychological safety at work are crucial. Secondary objectives, skills, and treatment. You may improve the skills and the well-being at the individual level by cognitive reframing and CBT, biofeedback and stress management, assertiveness training, mindfulness-based intervention, and if necessary, early clinical treatment of disorders, if any, anxiety or depression or substance use, for example. The key message is that primary prevention, which means work redesign, has more durable effects. The organizational psychiatrist is uniquely placed to influence both levels, which means work redesign and individual level of intervention. Should psychiatrists treat organization? The role of psychiatrists is gradually shifting from treating pathology at work to proactive evidence-based primary prevention. Why should psychiatrists treat organizations? Because it enables genuine prevention, supports a public mental health approach. System-level change lasts longer with the help of psychiatrists. Evidence supports organizational action, and it fits occupational medicine practice. Why should psychiatrists not treat organization? Because there is a risk of conflicts of interest, loss of therapeutic neutrality when you treat patients and influence the organization at work at the same time, possible employer pressure on clinicians, limited evidence for some interventions such as CBT or mindfulness used alone. It blurs clinician and consultant boundaries. So you should be careful to balance clinical independence and systemic or organizational influence as a psychiatrist. So what are the key takeaways? There are 5 paradigm shifts for the organizational psychiatrist. First, burnout is a syndrome, not, until now, a diagnosis. Screen for depression, anxiety, and substance use before labeling and before considering it's only burnout. Second, leadership behavior is a powerful clinical lever to improve well-being at work. Toxic leadership multiplies risk. Supportive leadership is very protective. Third, sex and gender shape occupational risk. Women face specific, under-recognized occupational mental health risk, especially at certain periods during her life. Fourth, primary prevention outperforms treatment of the individual at the individual level. System-level change, such as job redesign, better leadership, psychological safety, produces more durable results than individual therapy alone, such as CBT, mindfulness, physical exercise, for example. Fifth, the dual role is a tension to manage for the psychiatrist, not a title to claim. Influence systems while protecting clinical independence and neutrality of the organizational psychiatrist. These are some references that you can use from WHO 2022 for the ILO, International Labour Organization, 2016, and some reviews about, for example, the theoretical frameworks used and the state of the global workplace report in 2025 and a meta-analytic evidence on CBT for work-related depression and anxiety in 2022. Thank you very much for your attention.